Good afternoon. So I'm Catherine McDermott. I know many of you, but I'm going to introduce myself. I am a psychiatric mental health nurse practitioner, and I do primary psychiatric care for patients with dementia. I work some in the assisted living facilities, and then I also have a private practice and see patients in the community and many of our members here at Town Square. And I provide this educational series once a month. And I usually talk for about 40-45 minutes and then take questions from you guys, and we kind of go from there. So today's talk is on agitation, which I'm sure many of you face these challenges with your loved ones with dementia. So we're going to talk about it. We're going to talk about what it is, and then we're going to talk about how we treat it. Okay? All right. So what's the definition of aggression? Is forceful behavior, action, or attitude that's expressed physically, verbally, or symbolic. So a lot of times people think agitation is just when somebody strikes out at somebody physically. But a person can be verbally aggressive and agitated, right? And how does that show? It shows with tone of voice, it shows with facial expression, it shows with body language, right? Their attitude, they can be very argumentative or even somewhat dismissive or withdrawn can be sort of a form of agitation, right? Where they're just won't engage. You're asking them to do something and they're not willing to even engage in the conversation. That's a form of agitation and aggression as well. Symbolically, again, it can be raising a fist, right? Like they're not really going to hurt you, but they're showing you a sign of force, right? So this is something that we very oftentimes see with our dementia patients is that they get very frustrated easily, and they'll raise a hand, and it can be very out of character from their normal personality when we see this, and so it can be really quite shocking to us. Okay? When we talk about dementia and we talk about the inability to understand and process information, I've talked about this repeatedly before, that many patients with dementia develop anxiety because they cannot understand what people are asking them, what people are telling them, what people are doing to them. I see this a lot in the assisted living facilities where the aide, the resident assistant, is tasked with giving somebody a shower or changing their brief. So here's a person who you don't really know. Yes, they might be wearing a uniform and a name badge, and they walk up to you and they want to take your pants off. And you don't know who they are. You don't know that you've soiled yourself or that you're wet. You don't understand that. But our primal goal is to protect ourselves. So that's when we talk about innate drives. If somebody comes up to me and tries to take my pants off, my natural reaction is to withdraw, to hold on to my pants, to hit them so they'll stop doing this to me, because I don't understand why they're trying to do this. So many of the aggressive and agitated behaviors that we see in patients with dementia comes from their inability to understand the stimuli that's coming in. It's a defense mechanism. They're trying to protect themselves because they don't understand what's going on. We can tell them, right? We can tell them, you're dirty, I need to change your brief. They might not be able to hear it and process that information. We can show them, walk up to them gently and say, I'm going to show you on yourself, I'm going to take your drawers down, right? So they see, okay, this is what's coming, right? We're helping them try to process that information in a different way than we're all used to. Because if I said to all of you, I'm going to take your pants off, you all know what that means right away, right? Because you're cognitively intact. But people who are not cognitively intact have difficulty understanding that. So the more we can give them verbal and auditory cues, the better off we are to not startle them or help make them be anxious in order for them to feel that need to protect themselves. Again, often a result of threatened ego, it's kind of that same idea, right? And it's manifested by either constructive or destructive acts towards oneself or against another. We just were meeting with a patient who, when he gets frustrated, he bangs his head against the wall. Well, that's destructive against him, right? Not anybody else. Sometimes he gets aggravated with his wife and throws a water bottle across the room. That's, more directed towards somebody else. So these are some of the behaviors that we oftentimes see. All right. So now let's talk about agitation very specifically in dementia. So one of the things that we see with agitation and dementia is something that we call motor restlessness. And I hear this from families all the time, right? He just won't sit still. I can't get him to sit down. He's wandering all over the place. He moves things from here to there. He's just uncomfortable in his own skin. That's a form of agitation. Emotional distress or dysregulation. So in Dr. Cummings' book, and when we look at the demential behavioral assessment tool, we're trying to stage people out. In stage 5, one of the things we see is catastrophic reaction to certain things. So a glass drops and breaks, and the patient with dementia just bursts out into tears, sobbing and wailing over, like, it's a glass, right? Yeah, because it was upsetting for them. And their reaction is because they don't really understand the consequences anymore of things, right? Or there's a loud noise and they get startled, and now they're very anxious and they can't seem to calm themselves, and you can't, the noise went by, you heard it, it startled you, and then you just move on to the next thing. They get stuck and they can't seem to move past those things. Sometimes they're unwilling to talk, so I kind of mentioned that before, right? They just totally go within themselves. They don't engage. You're asking them, come on, honey, it's time for dinner. Come up, come get up, and they just look at you and don't do anything. So that's that. Some of that is, again, we have to sort of tease that out. Is that processing that they can't really understand what it is we're trying to say? Or is that a form of, yeah, I'm just not going. I'm not doing that. And sometimes we don't know why. And sometimes we can't tease that out, right? And sometimes they're over talking. And this happens a lot too, especially in the facilities too, where they'll just be walking around talking about really nothing, just over and over. Sometimes they'll be saying the same thing over and over and over again, or they kind of get stuck in some sort of a rut, something, and they, and you can't even understand it. Sometimes they want to find their old home where they were a child, or they're looking for their parents or whatever, and they just constantly verbalize, and that's a form of agitation as well. When somebody is agitated, when a patient with dementia is agitated, they're unable to concentrate even to the ability that they're able to do. So we oftentimes talk about redirection, right? We've heard that word a million times in my talks, right? So we don't want to reorient the person. Like, we don't want to say, oh, your mom died 10 years ago. She's not here. We want to say, why don't we come over and sit and, read a book or look at a picture book, or, do this puzzle, or whatever the activity is that we're trying to get them engaged in. When somebody is agitated, right, and anxious, they can't do any of that, even though they want to, right? They don't want to feel the way they're feeling. They want to be redirected and sort of brought out of that moment, but they just can't. They can't bring themselves to do it. You bring them over, you sit them down, they start to do something, and they're up on their feet again in 2 minutes. They have a very low tolerance for, like I was talking about, the events that cause the catastrophic reactions, things that, wouldn't really even faze us. People with dementia very oftentimes can't tolerate loud music, and even sometimes here in the center, I'll have to remind the staff, like, okay, that's a little loud, or the beat is a little bit too fast, right? The idea is not to overstimulate the person, right? We want to keep their mind active and busy, but we don't want them to where they're like a raw nerve, because they do have a low tolerance for a lot of those things. So as we get into some of the things that you'll do to help with the agitation, you'll understand where that comes from. Another way to sort of tell if somebody's feeling anxious or agitated is if there's sudden changes in mood. So they're fine 1 minute, and I'm talking minute. It changes by the minute, right? They're fine 1 minute, and the next thing you know, they're crying and lost in some thought that's very troubling to them. And then the next minute they're withdrawing and they don't want to talk to you. And then they're up wandering around, moving things and waving their hand at you. And you haven't done anything. You've literally sat back and just watched it unfold. And it's this, what we call mood lability, and we see it a lot in patients with dementia. Because all the stimuli is coming in, they can't figure any of it out. They're trying to figure out how they're going to react to it. Explosive or unpredictable anger. You know, I go over this times and I think to myself, is it really unpredictable? Like most of the time, like 90% of the time when a dementia patient has an explosive episode of anger, there was what we call a precipitating event. I'll get notes from the assisted living facility and they'll be like, you know, Mr. Smith, you know, hit another resident. Okay, my first question is, what did the other resident do to Mr. Smith to make Mr. Smith hit the other resident, right? There's usually a precipitating factor. I mean, it could have been something as simple as she pushed her walker in front of him and he didn't want that to happen, and so he got agitated and hit her, right? It's very unusual for a patient with dementia without provocation to try to strike or to be, you know, overtly agitated, have a huge outburst of anger unless something has happened. Now, there are people that have, you know, PTSD or underlying other mental illnesses. Things may be going on in their brain that we don't know about, right? And we hear a loud noise and they have a history of being in the war, and now they are, you know, back in that war zone again, and now they're angry and up and yelling. And so, but again, it's a precipitating factor. We might not know what it is, but there's oftentimes a precipitating factor. And then repetitive behaviors. So a lot of times with the repetitive behaviors, we see sort of self-harm. They pick at their faces, pick at their hands, pick at their legs. Some of them will, you know, rub clothing until they're literally raw on their skin. These are the types of repetitive behaviors that we see again with the anxiety and the agitation. Have any of you seen any of these behaviors? Yeah. Okay. So it sort of resonates with you that this is what we're looking at, right? Okay. All right. So we talked about what we see. Now we're going to talk about what causes it. And I kind of mentioned some of these things, like when we talked about the overstimulation. But let's talk about limited executive function. Now, I've talked about executive function before. I'm just going to give you a real quick definition of executive function again, so that we understand what it is. Executive function is our ability to carry out a complex process, right? Cooking without a recipe requires executive function. Even cooking with a recipe requires some executive function, right? You got to be able to figure out how to multitask, things that you have to do at the same time, or perhaps right close to each other in order to pull it all together, right? We need executive function, and I use this example frequently to take a shower, right? We've already talked about that. How many steps does it take to take a shower, right? You have to know how to sequence it, right? You're not going to use the conditioner before you use the shampoo. It's just how we, now there's not danger, at least, in executive function that you've lost in taking a shower, except if you can't even remember to wash yourself and then you go for a long period of time, you know, unclean. But executive function in things like knowing how to take your medication, right? Knowing how to drive your car, knowing how to plan and carry out most of your activities of daily living, right? How to get dressed, how to go to the bathroom. All of these things require executive function. And so when the person has limited executive function and yet they're tasked with doing those things, it causes frustration and agitation, right? So when we say to mom, go in the bathroom and take a shower, and mom has limited executive function, mom's going to get agitated with us. She doesn't want to go in and take a shower. She doesn't know how to take a shower. She's not going to tell us she doesn't know how to take a shower because she doesn't have the insight to understand that she doesn't know how to take a shower. She just knows that she doesn't want to do that. And so she says, I already took a shower. I don't need a shower today. Because she's not going to do it, and she gets agitated with us. Limited executive function. We ask a patient with dementia to do more than they're capable of doing. That's why. Neurotransmitter dysfunction. So I talk about this a lot when I talk about the medications that we use, not to treat dementia, but to treat the side effects of dementia, right? What are the mental illnesses that we oftentimes see with people that have dementia is anxiety and depression. And we know that as we age, there isn't anything in our body that ages the same, but yet we sort of feel like our brain, should be able to use those neurotransmitters that we have made to mediate our mood, right? We feel like that should be sort of normal, that, our brain can still mediate our mood. But when we have dementia and we struggle every day to understand the information that's coming in, and we feel like we're constantly under stress and duress, and we burn out those receptors in our brain for those neurotransmitters. So serotonin, norepinephrine, dopamine, all of our happy chemicals we can't use as well. And that's what causes the neurotransmitter dysfunction. And so when we get to treatments, you'll understand a little bit more of that when we talk about that. Anxiety, we've kind of hit on quite a bit. It's pretty much, I probably should have put it at the top, it pretty much is the number one cause of agitation. When a dementia patient feels anxious, when they feel like they can't understand what's happening to them, they get agitated. Overstimulation, like I said, a little bit of music is nice. That doesn't mean that, blaring rock and roll music at, the top of the volume spectrum is going to be, or repetitive sounds over and over again. I find that a lot of people have, ringtones or dings on their phone, and we don't even think anything of it, but the dementia patient is very agitated when they hear the same sound over and over again. It's overstimulating to them. They don't understand where it's coming from or why they keep hearing it. Unmet basic needs. So, this one is very difficult because we want to be respectful of the person that we're caring for, right? And it seems somewhat disrespectful to ask your spouse if they're cold or if they're tired or if they're hungry, right? Because that's what you ask a child, not your spouse, not your mother, right? But we have to remember that they don't oftentimes have the ability to tell us what they're feeling. They may not even know that they're cold, and that's why they're anxious and agitated. They're just physically uncomfortable, right? And so we have to anticipate those things for them. Just like the temperature in here was chilly. I knew right away that that was uncomfortable for me, and I was able to articulate that. But a lot of times our dementia patients aren't able to do that. They just become agitated. And so we have to sort of watch out for those physical cues that they're hungry or tired or cold, or that there's one of the other ones we see on a fairly regular basis is that they're constipated or they have to have a bowel movement. If you have to have a bowel movement and you feel yourself getting ready to have a bowel movement and you do not know where the bathroom is, anybody ever been in that situation? Right? There is nothing more anxiety producing than that. So all of a sudden you're out with mom and she becomes a wild woman. Can't get her to calm down. She's pacing all around. She's got to go to the bathroom. You have to think about unmet basic needs. Pain is another one that's really important, and we don't think about it enough. Pain can cause horrible anxiety and horrible agitation. I had a woman just a couple of weeks ago, a patient we saw today, who's actually on hospice services and terribly agitated. She was either sleeping, or if she was up and awake, she was hitting people for no reason. She'd walk by people and would hit them, would throw chairs over. It was just like a disaster. And the hospice doc called me and said, I think we should go up on her Seroquel. And I said, I don't. And she said, well, what do you mean? She's agitated. I said, yeah, she's been on that dose of Seroquel and her agitation has been controlled. Something else has changed. So I said to the patient, are you in pain? And she said, I ache here and there. She couldn't really articulate what was wrong. She couldn't really tell me. I said to the hospice doc, let's try a little tramadol. So we put her on tramadol. She's a completely different person because her pain is treated. We saw her today. She was pleasant. She still can't really, she had no idea who I was or even why I was there, but she was comfortable in her own skin. You could see that anxious and agitation was gone. And I didn't use an anti-anxiety medication. I used a medication to treat her pain. So we have to think outside the box. We have to think about those things that we wouldn't normally think of as to what's causing the anxiety and the agitation. Okay? We kind of already went through executive function. Does anybody have any questions about executive function? The only other one I wanted to talk about was impulse control when it comes to executive function. Sometimes what we find with patients that have dementia is that as their executive function declines, their impulse control declines. So, and this can be an issue certainly socially if you have a male who has lost some of his executive function, his impulse control, and he sees an attractive woman, he may make a comment, he may try to touch her in an inappropriate way, because what we know is socially appropriate behavior disappears when you have dementia. And that's that many times people say, well, she's lost her filter or, that sort of thing. That's where that comes from. They lose their social skills. They don't realize that their impulses just can't be satisfied the minute they want them. And that's sort of that regressing back to almost like a child who doesn't understand that I can't eat all of my Halloween candy on Halloween night, right? They don't have the impulse control to stop themselves from doing that. That happens with patients with dementia as well. But the rest of it, I think we went through working memory, flexible thinking, emotional control. Okay. All right. We talked about the 3 neurotransmitters that are the most important that we use to control agitation. So dopamine is alertness, pleasure, reward, motivation, and euphoria. Dopamine is what we all like, right? It's what we crave, dopamine, right? Norepinephrine is our focus. It's our fight or flight. It's our arousal. It's what gives us energy and motivation. You get up in the morning, you open your eyes, and if you don't have enough norepinephrine, you don't want to get out of bed. You just want to stay there. You have all these things that you need to do, absolutely no motivation to get them done. That's a lack of norepinephrine. Serotonin, pleasure, relaxation, contentment, positivity. That's how we feel when we're home, right? How many times do we hear dementia patients say, I want to go home? Home's not a place, home's a feeling. Home is where we feel pleasure, where we feel relaxed, where we walk in and everything's familiar. It smells familiar. We recognize our furnishings, our things are there. We can kick off our shoes and sit on our comfy couch and pull up our blankie that smells like we know, and we feel that contentment. That's serotonin. When you used to enjoy listening to music all the time, you couldn't live without the music playing in the car and on the stereo and all through the house, and now all of a sudden you just really don't care. That's a lack of serotonin. Apathy. You just don't even care anymore about the things that you used to do. So anergia, lack of energy, norepinephrine, serotonin, the inability to enjoy, and dopamine, no motivation or pleasure. It's kind of the combination of the norepinephrine and the serotonin. Okay. Dopamine is that rush of neurotransmitter that we get when something amazing has just happened to us. We get engaged, we win the lotto, even if it's $500, you get a rush of dopamine, right? Something positive has happened to us. Dopamine, physical touch, intimacy, massage, dopamine. Okay. Anxiety. So we talked about the agitation, what it's caused by. It's caused by anxiety. And anxiety is the fear, the feeling of worry, nervousness, or uneasy, typically about an imminent event or something with an uncertain outcome. That's what dementia patients live with every single day. They don't know what's coming next. That's why they ask the same question over and over again. When are we going home? When are we going home? Do we live here now? Why did we come here? Because they don't know. And so they're going to ask that question over and over again because they have that uneasy feeling about something that's happening because they can't, in their own mind, come up with what's actually going to happen next. And so, yeah, that's the rest of that is just really that it's a perceived threat, and they do avoidance behaviors and often physical symptoms such as an increased heart rate or muscle tension. Like you can physically, viscerally feel anxiety. You can literally see people who are anxious because of the way their body language is, the way they present, right? Their shoulders are up like this and they're shaking and they're agitated, and that's anxiety presenting itself, especially in somebody with cognitive impairment. One of the things that I want to mention here really, really strongly is that very often anxiety occurs when we reorient the person with dementia. So let's talk about reorientation versus redirection, right? If I don't know that my mother is not dead because I'm looking for my mother, is it going to be helpful if you now tell me that my mother is dead? People will say to me, well, I don't want to lie. You're not lying. I tell people, we tell children, don't talk to strangers because we don't want them to talk to somebody and get hurt, right? But we don't say, well, don't talk to strangers because there's rapists and murderers out there and somebody's going to come and take you away in the middle of the night. And we don't go into that kind of information because it would be distressing to that child. We don't share information with the person who has dementia if it's not going to be helpful to them. We live in the world of half truths. Where's my mother? I don't know. But I know that she's happy where she is. Well, that's true. I know you're going to see her soon. Well, that's true too. We haven't lied. We just haven't been fully truthful because the truth would be hurtful. If I say to my husband, do I look fat in this dress? Do I really want the answer to that question? Same thing. He's not lying. He's being judicious in the amount of information that he gives. Bar none, that is the number one failing that I see with families, is that they overshare information and then the person with dementia becomes anxious and upset. They cannot process that information any longer, and all it does is upset them.